The first patient is a 64-year-old male. He was diagnosed with a large intrahepatic cholangiocarcinoma back in 2016. Afterwards, he underwent 3 lines of chemotherapy for downstaging, but there was disease progression. After several ERCPs and stent placements due to intermittent cholangitis, and there was a progressive dilatation of the bile ducts in the left liver lobe. At the last ERCP session, there was no further treatment options with the ERCP, and a couple of months back, the patient got a PTC with external drainage of the left-sided bile ducts, and due to insufficient drainage, the patient is now scheduled for EUS drainage hepatogastrostomy. His bilirubin is now 75.
I just want to supplement a little bit, because some of the problems that the patients now face is not a good quality of life. He has a lot of fluid alongside his PTC drain. The radiologist tried to get a stent through the stenosis, but was unable to. And we discussed that it would be better if we could turn the left side of his bile duct, drain that to the stomach, in order to get rid of his external drainage. So this is let's say, the thoughts of the good indications for this patient. So if you are ready in the endoscopic room.
Hello, everybody. Can you hear us?
Can you hear us?
We can hear you now.
Okay. Good afternoon, everybody.
Amazingly, we can see you.
Don't worry, Peter. Your magnificent team up here has everything under control, so we're just following their lead. So we are here in the room, Rusty and Lasse, together with this magnificent team. We got a 64-year-old male, as you have known. We are in these suits because he's positive for RMSA. We've seen the CT scan, and he's got a large tumor burden, metastatic in the right liver lobe and left liver lobe with cholestasis. We've improved on the cholestasis by injecting 35 cc's of sterile water into the PTC drainage. And he has, when you see the fluoroscopic picture, 3 stents in place in the common bile duct, 1 metallic stent and 2 plastic stents, and then the functioning PTC drainage. The rest I will leave up to Rusty from here, who's got the scope in position.
Yeah, hello. Good afternoon again to everybody. Once again, you have seen the summary, or you have heard summary about the patient. What is important here that we are not pressed to perform the drainage because of patient's deteriorated liver function test, but mainly because of his quality of life. He's got reinserted his PTC a few days ago on 8th of November. It means last week. Thus, bile ducts are not enormously dilated, and mostly centrally, as if you can perhaps appreciate on the EUS scanning. Centrally, there are 6-7 millimeters in diameter. You can also see here inserted PTC drain. I was initially looking for the option to do it from the segment 2, but it doesn't seem to be a very good window of opportunity. And even though we needed to fill left-sided intrahepatic bile ducts with a saline, with a sterile saline, in order to do a little bit more better coupling because of the air. And of course, limited diameter of the bile ducts. So it seems that we may have in segment 3 this window of opportunity where we will try to insert EUS-guided hepatogastrostomy. Once again, with the main indication to help patient with his quality of life, to improve his quality of life. I hope you have seen also CT scans. I'm not sure if you had an opportunity to see it, but there is no dilation of the right-sided intrahepatic bile ducts, and basically right liver lobe is filled by the huge metastatic cholangiocarcinoma. It doesn't seem to be very much functional parenchyma or residual liver function. Is there any questions now from the audience?
No, I think it's fine if you proceed. If you think you have a good window, then then please proceed.
We're getting the 19-gauge sonotip needle in place here.
I prefer, for this type of procedure, I prefer Medi-Globe needle. It's, of course, off-label use for interventional procedures as the needle to establish access. The same needle I'm using also for pancreatic anastomosis, pancreatic gastrostomy. What I prefer for this needle is its sharpness, and also what I prefer it's that it's not bending. It's relatively keeping its shape. We have already filled bile ducts with some saline, but probably we can fill it slightly more.
I think we will try to work on the ultrasonic view because they lost the ultrasound while trying to get the RCP image.
10 cc's.
But I think they try to swift.
Can you see ultrasound image?
No, actually not. They are trying to with the camera to. But now I see it. Now we see it through a small window here. We see you have stuck the needle in.
I'm supposingly to be in the bile duct. Of course, we always need to bear in mind about concomitant arteries and veins. So I will try to carefully withdraw stylet.
That's better. Now we see the ultrasonic image perfectly.
May I get a saline? No, give me contrast, please.
Yeah. Do you always use contrast here, or is it only...
I always use contrast. I cannot hear you very properly, Peter, but I guess you asked me if I always use contrast. Yes, you need to verify your good position, that you are in the bile duct and you are not anywhere else, especially in any vein. But can you see X-ray now?
Yeah, we see.
Okay, perfect. I think we can nicely see bile duct, even some filling on the right side. Yeah. We do not need to overfill. We don't want to induce cholangitis. Now, saline. Sterilban. With a spray. I will just flush needle and I will ask for the 035 Visiglide. Which is also guide wire of choice for me for this type of procedures, just simply to
it's a little bit more stiff than the second generation Visiglide. Is that so?
I prefer first generation because of stiffness and because of maneuverability, and I actually prefer straight guide wire over angled guide wire. This is a very good example where we sometimes would prefer to have a dedicated EUS access needle, which also can bend, which also can be more flexible and more control of direction of the guide wire instead of just using control by guide wire itself. Yeah, we haven't shown it, but there was not really optimal window of opportunity from the liver segment 2. Okay,
and what you might appreciate also is, as Rasti said, now we see actually a filling of the right side of the right liver lobe, which we couldn't see on the PTC cholangiography. So maybe we could hope for this patient that actually this stenting will mean that the bilirubin level will will fall down to a normal level, or at least a level where the patient isn't that bothered by his jaundice. But what we saw previously was a selective filling of the left liver lobe, giving us an indication that the tumor masses was obstructing completely the right liver lobe.
So it is.
I'm trying to proceed guide wire.
Yeah.
Further on,
It ends somewhere, probably in a liver.
No, it's. Okay.
So you.
Yeah, we can try a little bit with more filling, and we try to puncture again. But so far, no harm is done. We can just proceed.
I'm filling up.
Yes.
Coming in there.
Oh wow, that's good.
That always helps, you know.
Yeah.
The basics of ultrasound shows here.
Det er fint. Det er fint. Ja, jeg tror, at
That was better.
Kunne du give mig noget saltvand? Fordi jeg 10 ml saltvandssprøjter. Giv mig 3 af dem.
Still goes cranial.
I try to do it from different angle. Yes, please.
Somewhere.
Okay, I think that we might be in a bile duct now.
Tip is a little difficult to see.
Yeah, can we do filling of the PTC with a contrast?
Yes. Contrast. Okay. Lasting 2 seconds.
Yes.
And I'm now filling from the PTC drainage with contrast. We've been filling with sterile water so far, but I'll be filling with contrast now in order to see where the Rasti is, and I'm filling with contrast. I'm filling up with contrast.
Okay.
Can we see the X-ray?
Yes. Can you see X-ray?
We had 3 images a while ago. Couldn't we get that again?
Ja. Det er fint, når jeg får den nu her. Og det er det selv. Yes.
Yeah, better.
Can you feel contrast again?
Yeah, 2 seconds. I just have to shift. We're feeling more contrast.
Yes. Okay. Okay. The position is not super duper ideal because there is quite a big angulation of the echo endoscope, but still we may try to keep it in a stable position.
You want to contrast?
No, we are fine. We are fine.
Good.
Okay, we'll push guide wire in.
So you have the guide wire in?
Yes, we have guide wire in.
Yeah. Now I see it.
Okay, that's not good enough. That's not good enough. Okay, stop.
Perfect.
Okay.
You want all the contrast?
I have. Stop, everybody. I have now pushed guide wire. Even better, I'm in a confluence with the tip of the guide wire. Now, can we slowly introduce the guide wire? Push guide wire in. Yes, go in, guide wire. It's okay. Go in, guide wire.
Good.
Okay, more in guide wire, more in.
Actually, it looks as if you get into the right.
Sorry, excuse me, Peter.
It could look as if you get the guide wire in the right side of the patient as well.
Yes, but we try to actually avoid it. If you look at CT scans, we don't really need to do anything with the right side. You know, patient doesn't have a cholangitis, and there is no dilation. There is a huge tumor. But what helps us this vision, what we can see now, this visualization, that we can see that there is still we can pass beside the self-expanding metal stent, which is inserted transpapillary.
Yeah,
and a patient has actually 2 plastic stents there as well. Probably this would be also for consideration to do intraductal RFA for this patient. Yeah.
Den kommer ikke ud af munden. Den kommer ud her.
Would you consider doing an antegrade self-expandable stent in such a case?
No, I think that patient has enough things that, yes. Patient has already 2 plastic stents.
Sorry, just
I would still.
Do we have the guide wire locked?
I have guide wire. I'm holding guide wire. I'm sorry. Please, can you just pull the needle? I would still do hepaticogastrostomy. For patient, it will be better. You know, I don't know. Prognosis seems to be very poor if one looks into his CT scans. It's really advanced stage of disease. So I would still perform hepaticogastrostomy.
Want the balloon
we can always work on the both sides. If I should do something, if I would propose to do something transpapillary, it would be to remove plastic stents, perform intraductal RFA, kind of renew the patency of the self-expanding metal stent, and insert 1 10 French plastic drain through the previously inserted transpapillary SEMS. So what we do now, yes please. What we do now, we will dilate our punction site with a 4 millimeter dilation balloon. I'm not using very frequently cystotome, which you can know that it's often described as a literature, how the next step to dilate the channel or a fistula of this channel. But I'm using, instead of that balloon dilation, what I'm trying to avoid is a thermic injury of concomitant arteries and veins in the intrahepatically. And when I do the dilation, especially through the wall of bile duct and liver capsule, so I just simply insert semi-covered self-expanding metal stent in the bile duct.
You know, this is.
I only use cystotome in those cases where penetration is not actually possible, like patients with a cirrhotic liver or multiple liver metastasis, where it's very hard to pass the balloon. it's very important to keep the stable position. And actually, yeah, this is a EUS meeting, but now your EUS image is, you can almost completely disregard it. You are not using it as much as a reference. The most important is to keep a good position. And now we're going through the segment 3.
And you use
it's more stable if you go through segment 2.
X-ray.
It's let's say it's easier, but there was no optimal window of opportunity. You have just to trust me because we have done it before. And of course, from this segment, it's trickier to keep the scope in the stable position, not to push yourself from the wall of the stomach. Can you see X-ray now?
Yeah, we can.
Okay. Now I'm trying to pass with the balloon to the bile duct. Can you see the tip of the balloon?
Yeah, it comes out now.
Okay. I am in the bile duct now.
Are you in?
Yes, I'm in completely in the bile duct.
Sometimes it's very difficult to get through the stomach wall, but you have had no problems here.
No, actually, I never have problems with this. Stomach wall is never big problem. Sometimes it's a fibrotic capsule of the liver and even very fibrotic bile duct. But stomach wall with this balloon doesn't present any major problem. What I would like to comment is actually type of the balloon I'm using, because it's not whatever balloon, but you need to use a balloon with a good pushability, with a balloon which is very stiff and has very good direct force while you're pushing it. And I'm using in this case hurricane balloon from Boston Scientific, which is one of the few balloons you can use in the liver hilum lesions, because other balloons will not pass through even if you have super stiff guide wires. Okay, now we need to just gradually dilate the fistula tract up to 4 millimeter, so it means 12 atmosphere.
Get the audience to see that you are actually in the liver. Just give us a slight amount of contrast.
Yeah, we can do that.
As you see here, we illustrate that the balloon
tip is somewhere here, I think.
I would be very disappointed if I'm somewhere in a portal vein.
No. So
yeah.
Okay. What might somebody you be thinking is that the SEMS that's in the common bile duct actually is working, because as you all can see, there's a filling of the duodenum. But probably this is due to that we pre-filled the left liver lobe with both sterile water and now contrast. So the increased pressure actually works in the way that it sort of pressures the contrast out of the SEMS, but it doesn't work from a practical purpose because the patient has jaundice and has biliary obstruction.
Okay, but the next step is now introduction of the stent.
Yes.
And you're using what is?
I'm using GeoBore. So it's a semi-covered stent from Tavon.
Yeah.
So proximal part is fully covered and places in between stomach wall and liver capsule, and uncovered part should lay inside the intrahepatic left-sided bile ducts. I will use, because ducts are not very dilated, I will use 8 millimeter in diameter and 8 centimeter in length. This type of stent you can get different types of different extent of coverage. This stent is equally semi-covered, so 4 centimeters uncovered, 4 centimeters are covered. Again 4 millimeter. Because this balloon is only 4 centimeter long, you need to sometimes do it twice and be sure that you actually penetrate also, or you also actually dilate also the stomach portion of it. Yes, so, please. Yeah. Once we dilate also this part, so I will proceed with GeoBore.
Yes, please. It would be nice to.
Yeah, I'm doing my best. I'm sorry.
No, you do an excellent job. Thank you.
It's very important not to lose your temper, because it's sometimes about slow movements. Yeah, Tom. Tom?
And you know, one of the tips and tricks here is never have the guide wire with a loop, then you're lost.
Yes.
Yeah.
Actually, you have to. I'm not very happy with this position. I have to be fair. This is not optimal. This may represent more challenges as soon as we get geobore here. So, but I will try to prove myself that we have done this several times before and manage it also through this position, because this angulation is not probably as challenging as with the balloon, but maybe more challenging with a stent. But
could we have all three images again?
Yes, I want stent. And can we flush it with the water, with saline through, so it's... You want the PTC drainage flush? No, stent.
Look, not too much like...
Is there any question?
We will let you work.
Yeah.
Huh?
So again, what I'm using, and my preference is use a stiff balloon instead of cystotome. Thermic injury is my major concern, and usually just surgical cleavage of the liver parenchyma shouldn't represent a major problem. And actually there are already stents which are based on this type of procedure, which is tip or kind of the dissecting tip of the introducer rather than using cystotome. So I don't think that for hepatogastrostomy, at least it's my humble opinion, that the answer doesn't lie with the electrocautery enhanced introducer.
But there are other
Can we flush it with the water? And
It is flushed.
Okay, and can we go?
Rasti, there are other people who always uses the cystotome.
I know.
So it's
I know,
so
and
there is a discussion here. Yeah.
Yes. Once again, I'm as a surgeon, I'm always concerned about delayed thermic injury, and we as all, regardless if our physicians and regardless if we are surgeons, we know the anatomy, and we know that all the time beside the duct goes vein and goes artery, and delayed thermic injury, even if you have a 6 French cystotome, creates quite a lot of heat. You know, the impedance is not optimal. There is quite a lot of resistance, so production of the heat is quite substantial. So bear that in mind once you do it. Can you see X-ray now?
Yeah, we see it.
Okay, so I'm proceeding. I think that I'm half...
Maybe the X-ray image can be enlarged. Would that help you?
I think I'm okay. Okay, should we start? Deploy? Yeah, can we enlarge? Stop. Can we enlarge X-ray image? Can somebody do it for me?
Kan vi forstørre billedet?
X-ray.
X-ray enlarge.
Yeah,
Press
sorry.
the button. Yeah.
Okay. Okay, perfect. That's nice. You should have come with this advice earlier. But thank you anyway. Okay, so you can see that we are actually with the tip of the stent very nicely in the slightly in the first branches of the left hepatic duct, and this actually looks very nice position to start with deployment of stent. So slowly start just to you know. Okay, please follow X-ray. You can see marker going towards PTC drain. Proceed. Go on. And just slightly behind the PTC drain, you can see so-called middle marker. Go.
And the point
you can do
of no
faster.
return.
Okay, stop. Actually, in this stop. In this case, this is not point of return, but this actually shows where is the covered and uncovered part.
Okay.
So,
okay.
so this is a little bit different. But what we need now to bear in mind is that we have extremely inflated stomach, and we need to deploy the stent at least like 2 centimeters inside the stomach. So if you can see now, endoscopic image.
Can we have the endoscopic image?
Yeah, proceed, deployment.
Please let us see the endoscopic image.
Deployment. Okay.
Can we see the endoscopic image, please?
Okay. Can you see endoscopic image?
No, we can't.
Okay.
Somebody wants...
Can you see endoscopic image?
Yeah. Now we see it on the screen. Yeah.
Can you see that, Peter?
Yeah, we see it.
Okay, we can see bile. So I think our business is done. What you have to evaluate this at this point is that it sticks sufficiently enough from the wall, and even consider just slightly pull it out if you are uncertain with the retus forceps.
We're told by the instructor that we need to change rooms now.
Okay.
This is a director's cut, so...
Okay, just a very last comment. I will pull it 4 millimeters more in the stomach.
With what? With
retus forceps.
Okay.
Just very carefully, you can do it, but very carefully, just to make a position, because once stomach collapses, so it will dislocate the stent. You need have like 2 centimeters inside the stomach.
Super. Thanks.
Okay, thank you.
That was
thank you for everybody.
impressive.
Thank you. Bye.